Morning, everybody. Welcome to the NHS and Life Sciences Commission, the inquiry session into health data. My name is James O'Shaughnessy. I'm a former Minister in the Department of Health and Social Care, and together with Professor Mike Buick, I am co-chair of the Commission. Before I go into this morning's agenda, I just want to provide a brief introduction to the purpose of the Commission. We all know that despite its huge success in innovation at a small scale and the alignment between life sciences sector and again, despite success in innovation at a small scale and the incredible alignment to overcome the pandemic, the UK continues to perform below its potential as a life science superpower. The pandemic response showed that the urgency of clinical need pushed the UK to maximise its strengths in clinical trials and population health to rapidly scale life-saving and life-changing innovations. The ambition for this government, and indeed any government, must now be to employ these lessons across the health system and to allow the life science vision to become a reality. Through an implementation-based approach, this Commission will publish an assessment of the key issues facing the NHS and the life sciences sector. We're focusing on placing innovation at the heart of the sector to improve health outcomes, increase economic growth, and critically to reduce inequalities. We are bringing together civil society, local, regional government, NHS, and industry leaders and policy experts. And in doing so, we will combine data, strategy, and critically case studies to which you are all invited to contribute to create implementable recommendations to overcome these problems. So that is what we are about. And I would like to just briefly hand over to the commissioners to introduce themselves. And I wonder, Mike, if I could start with you.
So good morning, everybody, and thank you for joining us. My name is Mike Buick, and as James has alluded to, I'm the co-chair of this part of the Commission. I'm really looking forward to hearing from you and our speakers today. And my background was as the National Deputy Medical Director for the NHS to Bruce Kew a few years ago, and I work independently providing technical support to various consultancies. And I'll move on from there, James.
Thanks, Mike. Corinna?
Yeah, good morning, everybody. I'm Corinna Bull. I'm a freelance health policy and market access consultant. I spent 10 years working in the pharmaceutical industry and now work primarily with small, innovative life sciences startups across the health and AI space.
Thanks, Corinna. Keith?
Hi, everybody. I'm Keith Ridge, and until February, I was Chief Pharmaceutical Officer for England, which I did for a mere 16 years, and before that I was a proper pharmacist, hospital chief pharmacist in Birmingham and Glasgow, and I'm really looking forward to the session today, an area I'm particularly interested in.
Thanks, Keith. Richard?
Morning, everyone. I'm Richard Stubbs. I'm Chief Executive of the Yorkshire and Humber Academic Health Science Network, or the AHSN, and also the Vice Chair of the AHSN Network, which is the collaboration of the 15 AHSNs working across England to spread and adopt innovation as fast as possible. I've been Chief Exec here for 6 or 7 years, but before that had a background in national policy, particularly NHS England, in the Innovation Directorate.
Thanks, Richard. And we also have Harpreet Sood joining for the second hour. Dr. Harpreet Sood is a primary care doctor and non-exec director at Health Education England. And Gillian Lang, who has just joined the Commission and will be observing today, a former Chief Executive of NICE, as I'm sure most of you know. So that is just a little bit about the Commission itself. I want to just briefly introduce the Health Data Inquiry session. I think we're all here because we know about the tremendous potential of health data. It is obviously an area both of great technical innovation, but also policy innovation, and not least provided by our first set of speakers, who include Ben Goldacre, Director of the Bennett Institute, and after whom there is a fantastic review named, just recently published. Welcome, Ben. We have Breid O'Brien, the Director of Innovation and Digital Health at NHSEI, and we have Claire Bloomfield, Deputy Director Data for R&D at the NHS Transformation Directorate. I'm delighted to say that they will be joining us for the full hour. Indeed, Ben will be staying on for the second hour. And they will shortly begin by providing 2-minute speeches or opening statements about the topics which we are investigating first, which are primarily around workforce and infrastructure. And then we'll be moving into questions where the commissioners will ask questions. For those of you who have joined, and I'm delighted to see a really fantastic audience in terms of its size and spread, please use the chat function to make comments. If we have time, commissioners will pull those out and try and pull them into the lines of questioning. I would also remind everyone that this is being recorded and will be put up online, so just to be conscious of that. So without further ado, I am going to ask Ben to give his opening introduction, and then Breid and Claire, and then we will move on to questions. Ben, the floor is yours.
Hey, thank you, and thanks for having me, and thank you for doing this event. I think it's really important to have some real deep dives around how we implement some of the overarching objectives. Just for background, my name's Ben Goldacre. I trained in medicine at Oxford and London, and then psychiatry at the Maudsley, then epidemiology at London School of Hygiene and Tropical Medicine, and then came to Oxford in 2015 to build a research group we're now called the Bennett Institute. And we're a truly mixed team of software developers alongside traditional academics and clinicians. And we take large health data sets and turn them into tools and services for NHS service improvement, as well as traditional academic research. In the review, which I admit is long, I recommend the 30-page version for those with a passing interest. We wanted to get away from trite aphorisms. We wanted to get away from saying data is so important and so powerful and we must listen to patients. We wanted to consider how this can be done in practical terms. And that's what the 117,000 words are about. But there are high-level insights, and in particular, some strategic necessities. So the high-level insights, which I'm delighted have been widely adopted, are stop sending copies of data to hundreds of different places. Instead, make that data accessible in trusted research environments, which have security benefits, but also efficiency benefits. Adopt modern open working, and then also embrace a coherent training program for the NHS analyst community. Now, those have in outline been adopted in the new NHS data strategy, which is a fantastic document. The challenge now is how do we do it? There's one open piece of advice in the review, which is build impatiently but incrementally. There's also a tacit piece of advice running throughout the review, and which I hope we'll discuss today, which is how we can build competitive markets in which we have a collaborative and competitive ecosystem that drives innovation. And that means in academia, in the NHS, and in the life sciences. And I'll stop there.
Ben, thank you for that. I'm sure lots of people on this call have read the review, but I mean, it really is a fantastic document with a lot of very deep recommendations, which I'm delighted to say, as you pointed out, the government is taking seriously. Breid, over to you.
Hi, thanks. Good morning, everyone. Hi, I'm Breid. I'm the Director of Innovation and Digital Health in the Digital Care Models team in NHSEI. And our programme of work is about utilising technology to support people at home. So this is about keeping people out of hospital, but actually working in partnership with them. And I think, you know, data is an inherent and really important part of that. But that I'm a nurse by background, an emergency nurse, and have spent most of my career working between improvement science and technology. So data to really drive improvement is, for me, is a really, really important component of what we do. But thinking about the supporting people at home agenda, and I've literally just come off a call with a patient, this is about really driving different partnerships with our patients. So for me, the ability for patients to see their data, to see their trend data, to really be able to self-manage is a really important component of what we do. And it's where we will move from that paternalistic dependency on healthcare to a much more of a patient-centered, patient-driven health agenda. So really delighted to be here. Through our work, we have patients using remote monitoring platforms, either continuously through wearables or through spot checks, entering data into apps, to basically monitor physical vital signs, but also how they're feeling, their symptoms, patient-reported outcome measures. So really thinking about how we drive a different agenda. And I'm not a data expert, but you know, through our program, we've got quite a few use cases where data can really make a difference. And we're talking about workforce, and I know, you know, what is the workforce we need to deliver this, but equally, how can this help our workforce really in productivity terms and help our patients in terms of really being partners in their care. And I will stop there.
Great, thank you. And I think in that statement, you remind us that workforce isn't just the people employed to provide care, that actually the workforce effectively includes patients as self-carers, and in making sure that data is in their hands, they have control and agency, and good use of it is critical. Thank you. Claire.
Thanks, James. Delighted to join Ben and Breid. So I'm Dr. Claire Bloomfield. I did the opposite of Ben in that I started in Oxford and moved into the NHS, and it's my 1-year anniversary this last week inside the NHS organisation. I lead the NHS Transformation Directorate's Data for R&D programme, and that programme itself and the £200 million investment that the government is making through that programme is key to making the goals in both Ben's review and the recently published Data Saves Lives strategy a reality. So we're really focused on taking all of those high volume of critical recommendations and converting those into practice in the next 3 years. In particular, focusing on improving trust in how the health and care systems data is being used for research and innovation. And that includes building out a range of trusted research environments at both national and subnational level. Before joining the NHS, I was CEO of an imaging AI consortium out of Oxford University at the Big Data Institute. And prior to that, headed up cancer strategy and was an academic neuroscientist. So have lived the academic experience of trying to work with the NHS and industry around data science, as well as trying to effectively build infrastructure to support and enable others' innovation. So have been at the coalface of doing this within Oxford and across the English ecosystem for imaging. I'm really excited to think about how we expand some of those lessons learned to make sure we can deliver on some of the recommendations and aspirations, but practically deliver over the next 3 years to really see a shift and transformation in the way that data is used for research and innovation purposes.
Thank you, Claire. I mean, you are brilliantly qualified to be part of this panel. Delighted to have you. I think this investment that you have flagged in the TREs is really significant. One of the things perhaps we'll explore this morning is whether that is enough or the end point, or what needs to be done beyond that to make sure that we really do provide that trusted environment for research. So I'm going to move on now to the two topics that we're going to explore in this first session. So we're going to move through the session to about 11 o'clock when Mike will take over and introduce the next topics. The first topic is about both the Tickell review and the review, Ben, that you and Jess and Maureen and others recently carried out. So in both those reviews, they outline the challenges in making sure that the NHS workforce, the current workforce and the workforce it might need to add, is sufficiently skilled and agile to utilise data and technology to the benefit of patients and the wider health ecosystem. So this is the first topic that we want to explore, and I'm going to hand over to Keith, who's going to ask the first question under this topic. Keith.
Okay, thanks very much, James. And as you say, this is an important area, getting the people ready to do what we need them to do. So the first question is, what training programs and competency frameworks must be considered for NHS staff and current leadership teams to enhance their digital and data skills? And I'm wondering, James, if Ben should kick that off. That's okay.
Please.
Thanks. Well, look, this is an enormous topic. I think there are three main food groups of personnel that we need to focus on. The first is NHS analysts themselves, the people spread across 160 trusts, a couple of hundred CCGs and various national teams who use data to find opportunities to optimize the logistics of delivery of care, which is all about improving the quality, the safety and cost effectiveness of what we do in the NHS. Now, at present, the NHS analyst community has been relatively neglected and left behind. Government Economic Service and Government Statistical Service and Government Operational Research Service provide a really clear roadmap of what we could do in terms of creating a profession that has clear technical job descriptions, continuing professional development, parallel systems of line management for people in those technical roles. And so our core recommendations in the review are that essentially that we should mirror the government analyst function, career pathways and training pathways in the NHS. And I think that's probably overall the recommendations in the review which have been perhaps taken up least energetically in the data strategy. However, I think there was already some ongoing work around Analyst X to try and push forward on that. And it is a big job and it could happen at any time. And it's not as mission critical, it's not as existential as the trusted research environments issue, I think. So there's a lot of detail in that in the review, but I'll park it there for brevity. There are two other food groups that we need to focus on. One is we need senior leaders with technical skills, because we need to use people with technical skills to manage complex technical problems, to make informed strategic choices about how we shape the ecosystem, and to be able to have the intuition or the insight to spot quick opportunities, but also to dismiss snake oil. So that means that we need senior strategic leadership roles for developers, data scientists, data architects. And in particular there, we need to think about how we can offer, I would say, leadership training for those in existing technical roles, and how we can make those kinds of roles more attractive to people from technical backgrounds, because the NHS is a peculiar environment to work in. I can tell you, as somebody who sits partly outside and partly inside, colleagues who are technical find their experience of working in large ALBs to be quite a dispiriting and confusing one sometimes. And I think we need to give training to people with technical skills to help them decode and operate effectively in those kinds of environments. And then lastly, we need people with crossover technical skills, people who combine software developer skills, hard won over 20 years of experience, plus domain knowledge of NHS data, the basics of epidemiology, NHS administrative structures, what doctors do with data and pop-ups, what commissioners are looking for in a service monitoring dashboard. Now that's much more tractable, except it does require probably that we take an approach similar to what we do with getting MBAs for people in the civil service, where you perhaps put golden handcuffs on people. You say, we'll pay for your training, but you have to stick with us for a year or 5 years or whatever. The challenge there is we are recruiting rather than selecting when it comes to getting people with software developer and data science skills into health and research software engineering roles, because they are so desirable in the jobs market. So we may need to think carefully about how we spend to save to create people with those crossover skills. So I'll leave it there, but happy to go on details.
Thanks, Ben. Sorry, Keith, did you want to follow up with the...
Yeah, could I just ask one follow-up for James? So, Ben, you and I have sort of discussed this a bit over the years as well, but the sort of who sets the standards is probably the question I'd like to ask, because in any profession, particularly healthcare professions, typically they're regulated, and ultimately it's the professional regulator that sets the standards. Now, whether the sort of government economic service sort of have a sort of form of that in a quasi sort of regulated way through setting their own standards in many ways. Who would set the standards for this sort of competency frameworks and such?
I think it's different for the analytic function that we were discussing, and then separately for the more technical developer skills. Looking at the analytic function, I think we follow the government economic service, government statistical service model. And I think there are some fairly well-established things. I mean, the DDAT framework that's been developed outside of health, I think is really valuable there. I think you couldn't directly lift and shift. There's probably a good degree more data communication that gets done by people who are data analysts in the NHS. And actually, that's one area where we really need to think about how we can become more systematic and structured about how we create a workforce that are capable of taking a graph, building a relationship with a clinician or a commissioner or a practice or a clinic and saying, look, we're not criticizing you, but this graph really does show that you need to stop prescribing NSAIDs without giving people proton pump inhibitor cover or whatever it is. So I think for those, there's a clear template that we can lift and shift from the analytic function in government. For people with deep technical skills around software development, data science, data architecture, and so on, there's a much bigger challenge because those are not certificated professions. As somebody who employs a lot of very high-end software developers, I can tell you that having a piece of paper that says you're a brilliant software developer is at best a weak risk factor for competence. In many cases, the best developers have got little or no formal training, and people with lots of formal training are often hopeless. Now, in addition to that, I think the state in general really struggles with new forms of technical competency. So we're really good at employing and recognizing and having tiered job descriptions and pay scales for the more old-fashioned forms of technical competence, like being a doctor or an accountant or a lawyer. We know, first of all, how to adjudicate on their quality with essentially sort of peer referencing from professions, and we have fine grains of specialisation and seniority within those specialties. We don't have any of that for things like software developer, data architect, and data scientist. At best, organisations that do well do a kind of snowball recruitment. You get somebody who's really good and they help you spot other people who are really good, and then you can build a good organisation around that seed. I think the best way forward on that is to accept those limitations around certification of more modern technical skills, and to focus really hard on getting people with deep technical skills in very senior leadership roles. Accept that they won't be writing code for you, that they will be managing other people who do, and recruiting other people who do, and guiding your strategic functions in the sort of broader remit of the organisation. And as I said earlier, to get those people, we will have to seduce them, we will have to shape them, and it will take a couple of years. But it will only take a couple of years. And one of the worst things that's happened in this space over decades is a kind of destructive impatience. Over and over and over again, you see people in senior leadership roles going, right, okay, I'm sick of this. We're just going to throw £1 billion out of the door and buy a thing, and hope that that will fix it. Yeah. I think we need to build impatiently but incrementally, and that means we need to build the people who are then the seeds for the next step of delivery.
One final thing, James. So that, I mean, I think you put it in the report. I can't remember, to be honest. But the a sort of chief officer role, I would say that, I guess, that you think could help.
So yeah, separately in the review, we do talk about certain roles, like, for example, a head of profession. I think that head of profession, though, we probably need multiple people, as in the same way that we do in medicine, who are different varieties of head of professions. So, you know, there's the president of a Royal College, which is different to the chief pharmacist or chief medical officer in NHS Digital, who is different to the lead person in a union. And one of the things that's been slightly disheartening, actually, was watching the admirable and very encouraging efforts of folk in NHSE to try and build out the analyst profession, was when they wanted competency frameworks and job descriptions and training programs written, there was almost no existing organizational structure for them to go to and just hand over the money that had the capacity to take the money and write that for them. That's how far behind we are. Yeah. The NHS Analyst Service has become this sort of accidental folk tradition of very isolated groups. And actually, you know, this is a public session, so everybody's a little bit cautious about being critical about individuals or organizations. I would say organizations like the Association of Population Health Analysts and the Faculty of Clinical Informatics are absolutely fantastic. They are run by energetic visionaries, but they are run by energetic visionaries almost as a hobby. And I think the state has taken the view that, well, you know, these professions should self-organize and it's their business to do so. Now, that may have been more practically feasible, I don't know, in the 17th century when the Royal College of Physicians was getting itself going. But I think relying on the Association of Population Health Analysts and the Faculty of Clinical Informatics being subsidized by member subscriptions, where in the case of the FCI, you have to pay 350 quid a year to be a member, I don't think that's realistic as a way to build a profession. Nationally, we want these structures and these workforces in place. If we're the people with the user need, then we need to pay for those communities and social structures and professional structures to be built. We can't expect people interested in clinical informatics or NHS service analytics out of their own pay packet to subsidise the development of a coherent structure around them.
Thanks, Ben. So I think what I take from that is there just needs to be much more central direction for the building of these professions, rather, as you say, rather than just kind of leaving it to emerge organically. Yeah. I'm going to, just because we need to move through the agenda, I'm going to move on, Keith, if it's okay, to Richard to ask his question. And Richard, as you pose your question, maybe I could just point the panel to a couple of questions that have come up in the chat, which may be relevant to what you're about to ask. The first is thinking about integrating the voluntary sector into the NHS data revolution. So in the pursuit of integrated care, we should be taking data from multiple sources, and of course, professionals working together from multiple sources with that data. So that might be one thing to consider. And the second point so that was from Harry Harrison. The second point that Samson and N talked about was a much more sort of technical capabilities around things like natural language processing and AI services, which may be something that Claire wants to reflect on as well. But Richard, I'll hand over to you to ask your question.
Yeah, thank you, James. And thanks, Ben, for those answers. Claire and Breid, just to give you a heads up, I'll probably come to you two first, I think, on my piece. I think Ben's incredibly well, he's articulated what we need to do, particularly from an analytical community point of view, and also, as Ben talked about, those with really deep technical skills, how do we get them into senior leadership roles, which I think is absolutely the right direction of travel. I'm also interested, I guess, in the rest of our 1.2, 1.3 million staff, and what is it that we can do both for our existing staff and our staff for the future to ensure that everybody is able to contribute to the UK's health data potential. What are the training programs, the induction programs, the competency frameworks that we can consider for the wider health and care workforce? I'm also conscious that Messenger, the Messenger review, which we haven't mentioned in this question, but he also picked up with Linda aspects of this, that we do need to think more deeply about how our general workforce understands the whole opportunity that this health data revolution provides for the NHS. So just really interested in that as a starter, really. How do we bring the rest of our staff with us? How do we help our existing staff to really get this agenda and value the kind of roles that Ben's been articulating so well? I don't know. So Breid, do you want to start?
I'm happy to. So I don't disagree with anything that Ben said whatsoever, but I guess if I'm thinking, as you just alluded to, Richard, it's about how do we get the data quality right in the first place? Because one of our biggest issues, I think, is that often our data quality in terms of input isn't always brilliant. So for me, and I think Ben's alluded to this as well in the chat, this is about how do we capture data? So really ensuring that systems we're using as frontline systems are user-friendly and people, it's not an effort to actually collect the data, but also I think it needs to be that it's not something separate. So I think in all core training, we need a really big focus on data and more about how data becomes information, becomes knowledge and insights, that whole piece, because so often we've got lots of data, but actually we're not changing anything because of it. So I think from a frontline perspective, trying to tell that story more. But also, as I alluded to earlier, this isn't just about staff, this is about our patients, our carers, and our voluntary sector. What is it that they're contributing to? And when we start talking about population health, the context in which people live, as well as their health and illness, is a really important point. So how do we start engaging more meaningfully in that? And my personal experience on facilitating a review of a shared care record was that is as much about trust between individuals as sharing data. So there's a whole people change piece here as well that I think we need to think about. And then just coming back to the point about, I think you really change people's perception of how important collecting and really understanding data is when you really tell the story. And that's telling both the quantitative data story, but making sure there's a narrative that brings it to life for people. So there are things, I think when we talk about competencies and training, there is about how do you create a sense of purpose for people, that this is important, has to go alongside that. I don't know if I've answered your question, sorry.
Well, I will come back to you, Breid, but you have. That's a good start for 10. Claire, any thoughts on the same question?
Yeah, thanks, Richard. Drawing some analogies again for some sort of the medical profession, I think some of this is around MDTs, but for data. So we need a technical workforce, but my observation would be is we need a multiplicity of expertise, and we need people that can bring the clinical, the technical, the public facing, the communications, the commercial, the contractual, all of those together to really harness the potential within data. And those different stakeholders have very different perspectives on the same data asset and the same problem, but will approach a solution to it in very different ways. So building that sense of MDTs for data from the front line all the way through the organization, I think that has to be a different way we approach this, rather than we leave data to the technologists or you leave data to the IT teams. It's everybody's job. And I think that comes back to Breid's point around a learning health system and how we're actually using data for insights. It's fantastic to talk about the concept of the longitudinal care record and the richness of the data, but we all know the reality of the quality of that data, the variability in that data. And that's because for a long time, how that data was actually being used for direct care, let alone planning, pop health or research, was not apparent to the people putting that data into those individual reports on the front line. So to get that quality up, there has to be that better of linking through to why this matters and what the goals and the impact of high quality data will be. And then there's a third strand, I think, for me, which is around partnership across the ecosystem. Is the NHS cannot compete with the life sciences industry and academia for the quality of expertise we need to drive this across to impact the whole of the UK. So we need better collaborative ways of working, moving teams between the organisations much more fluidly to actually cross-fertilise some of their expertise and understanding. In the same way we saw with clinical research fellows moving between the hospital and the academic environment, we need to do that for industry, academia and the NHS around data to really help rise the whole ecosystem and generate the optimum impact. So I don't think it's one person's problem or one group's problem, it's all of us.
Yeah, no, thank you both, completely agree. And there's a piece of work I'm doing with a separate hat or with the Academy of Medical Sciences around the culture of NHS careers and how we can get to a point where we can think about seamlessly moving from the NHS into life sciences and back again in a way that people can see career progression and the benefit behind that. Just my one follow-up, James, before I hand over to the second question is, as I did last night with some health education leaders across Yorkshire and the North East and some NHS leaders, and we were basically talking about the workforce of the future. And to summarise the conversation, in effect, you know, it felt like the NHS was looking back to our university colleagues to generate the curriculum needed to give us the workforce of the future. The health education colleagues were looking to the NHS to inform them about what we actually needed in terms of future roles, etc. When it comes to that wider education piece for the whole of our workforce, you know, any thoughts about where does the centre of gravity and the responsibility sit in order to be able to just define what a NHS member of staff of the future needs to know in order to be able to, as Breid say, you know, understand the quality of data and understand that this is part of everybody's mainstream role for the future? You know, who's going to drive that forward?
Nobody's jumping on that one. And I think it's because it's really hard to point a finger at somebody. I think there's an opportunity with integration of higher education in England into the NHS England family much more explicitly, that we start to dock that through from within the NHS. But similarly, as I think we saw with the genesis of the genomics medicine service and the integration of genomics into care much more explicitly in the NHS, there were whole swathes of new programmes that needed to be generated for the clinical workforce and others. So I don't think there's one solution, there's going to be one training course. I think there's a key role for academic institutions in terms of training. There's a number of doctoral training centres around health data innovation, but that's focused on use of the data rather than, again, top to bottom from the most junior members of the team actually inputting data all the way through the organisation. And I think that has to sit with HEE as a lead for at least those strands of core staff workforce within the NHS, embedding data much more explicitly, in the same way we're trying to embed research into the NHS workforce training much more explicitly as well, top to bottom.
Breid, any final thoughts on that, and I'll bring Ben back in.
No, similarly to Claire, I think it's difficult, isn't it? Because there are so many multi-layers to this that it belonging in one place may risk not getting that collective buy-in. So I think it's a really good question, but one that probably needs some further thought, because it's not just about education, it's about that coming back to that who owns it and that why we're all doing what we're doing. So yes, education, but I'm more interested in how we make it real for people who are working every day in health and social care.
Thank you. And just finally for me, Ben, really fascinated to hear your thoughts on that general workforce education piece.
Well, look, I agree with everything that's been said. And in the review, we talk a lot about training in clinical informatics and data fluency for senior leaders, as well as for people at the clinical coalface. Reciprocity is key, as people have said. The more that your data is used, the more its quality goes up. You will never see anything so immaculately coded in primary care as the things that are used to administer payments in the quality framework. And I think that should be regarded as a kind of general rule, that the more you give people something back from their data, the more that they will pay attention to improving it. I think on the workforce, just very lastly, some of the sort of historic strategic work on everything to do with data really reminds me a little of the story about the drunk person who loses their keys on the way home from the pub and only looks for them in the pools of light rather than along the whole journey. We focus a fair amount of effort in getting a dashboard to a chief financial officer. We focus quite a lot on doing the single analysis with a finished data set, because that's a reasonably high status activity, but it's also a familiar one. What we neglect is the vitally important pathway all the way from the raw data being collected by the clinician and the patient together through its curation, its secure housing. And the ABPI told us during the review that 80% of the work in an NHS data project, as far as they were concerned, was data curation. And they said that 80% of the spend from government should therefore be on data curation. And that's still an area that's being neglected. And that's because it's so hard. It's like staring at the sun. It's just enormous. But that's where we need to focus our effort on the hard problems.
Thank you all. James.
Thank you. I'm just going to very quickly, there's just one topic I really want to follow up before handing over to Mike to ask his questions, which is something that Claire talked about, but it's sort of inherent in everything. So talked about having a very skilled and technical, better skilled and more technical general profession. Talked about new kind of classes or cadres of data analytical, software engineer, other technical capabilities. But what Claire talked about was also working with the industry, which can afford to pay the salaries of, you know, highly skilled, highly and expensive technical staff. But on the topic of data, where the public are very skeptical, as we know from polling, of the access to their data by the private sector, by industry, by pharma, pharmaceutical industry, whoever. So what is the right way to harness those capabilities that sit in the private sector, and it could be in tech companies, it could be elsewhere, to the task of cleaning, curating, using, analysing NHS data in a way that kind of commands public trust? Really interested to get very brief because of the time, but Ben, Breid, or Claire's views on that. Claire, maybe I could start with you as you broach the topic.
Yeah, so I think from where I'm sat, there are two strands of curation. So there's curation at source as the data is generated, and then there is curation for very specific research and industry innovation questions. And those two aren't the same thing. So there's a data quality at source piece, and I think that rightly should, and it has to be driven through care. And so therefore has to be the responsibility of the NHS to drive up that quality at source piece. I think there is a secondary piece around how we're curating and reusing curated data that's generated through research and innovation to optimize the efficiency, that we're not all spending that 80% of time per project that Ben mentioned, curating often the same kinds of data for similar questions, not reusing that. Yep. So I think there's real scope there for better conversations across industry, academia and the NHS around how we use secure data environments to curate those data sets for research and make those reusable. So I think there's negotiations to be had around how we curate within trusted research environments, who does that, how that data product is then retained and used for the next projects that needed in the same space, which over time will start to create a suite of curated data products that will be reusable for a variety of different research use cases. So I think I'd make the delineation, at least in part, there between where we curate. Thank you.
I don't know if Breid or Ben would like to make a contribution before we move on. No. Okay, great. Well, I think you summarised it brilliantly. Thank you, Claire. So the second topic we'll move on to now, which is, again, an area which you identified in your review, Ben, which was the limitations to the UK's existing technical data sharing infrastructure and the lack of sort of systematic processes across the NHS to utilise data to support service design, re-engineering, and to improve outcomes. So I'm going to hand over to Mike to ask the first question on this topic. Mike.
Thanks, James, and thanks everyone for the contributions so far. They've been very good. And would Ben, perhaps I could direct the first one towards you, because you mentioned it in your introduction about stop sending individual data sets to people and let's find a way of sharing it. I just wondered, how can the infrastructure and technological requirements for patient data storage be fostered to improve health outcomes at scale? We talk a lot about sharing data to improve our health outcomes. How's that going to be achieved, Ben?
So the single most critical change that we can make is to move away from a paradigm of disseminating copies of records, albeit with names and addresses removed, to hundreds of different locations, and instead consolidate all analytic work for service improvement and for academic research and for innovation in a small number of shared trusted research environments. Now that's critical for a number of reasons. First of all, when you disseminate data out to lots of places, it is inherently unsafe. It duplicates risk. And I think people are alive to the risks of that now in a way that they weren't before. And that's good because it will head off catastrophes, both privacy catastrophes and 3 million people opting out. But moving to TREs also deduplicates a lot of the work. The current approach that we take means that we needlessly duplicate data storage. We needlessly duplicate IG. The same data is stored in dozens, hundreds of different places in slightly different computational environments, slightly different data schemas, slightly different headers. And that means that none of the work, none of the code is portable between those different environments. And that is a strategic disaster for getting good joined up, coordinated work and collaborative work across industry, academia, and the health service. So moving to TREs is absolutely critical. It will support efficient work, more secure work, and it'll also support open working. I think the challenge now is how do we create those in a way that avoids repeating the mistakes of the past? And in particular, the two big challenges here, I think, are number one, non-delivery. The one thing that everybody recognizes or mentions whenever you say, let's use trusted research environments, essentially researchers and analysts say, well, I've tried that and almost everything I've ever been offered has been dreadful. It's been brilliant in the PowerPoint slides, but when I actually log in, it's hopeless. So we need to be focused on how do we have a delivery-oriented approach? How do we create a competitive and collaborative ecosystem around platforms? And in particular, we need to create a workforce and a commons of knowledge and a high status cadre of people whose job it is to produce great platforms for other people to use. And the greatest missteps of the past, I think, have been that we have procured TREs usually by either giving a load of money to one very closed organization just to produce its own thing for itself, which isn't a trusted research environment because it's not shared, or we've given the money to people with adjacent skills. And in particular, we've given money to academic epidemiologists who are very good at producing single academic research papers, but who are not very good at producing platforms. And if you give data infrastructure money to epidemiologists, you will get epidemiology papers, but you will not get great data infrastructure. So we need to talk with UKRI and NIHR in particular about how we can support a rich collaborative and competitive ecosystem around data curation, secure analytics, and platforms for others to use, in the same way that they resource intermediate work like reagents in microbiology or work on single genes that are just a small component part of the pathway. I think we also need to think very carefully when we procure large data infrastructure from the NHS about how we can avoid the risks of vendor lock-in, which is another form of monopoly and another form of obstruction to a shared ecosystem where people are competing and collaborating as they go.
Okay, that's very comprehensive. And Claire, I just wondered, almost like in a policy world, how is that going to translate as we move to a different type of health system following the recent changes in policy?
So I think there's both a policy delivery aspect, and I'm fortunate or less fortunate, depending on which way you look at this, that I'm accountable for delivering some of the trusted research environments that Ben's just been describing. I think there is a piece, the policy is pushing us from exactly that piece around data sharing to data access. I think that is, we have to recognise, and I will quote Ben back at Ben, shift incrementally butt in patiently around how we approach that. It's a very big shift for the ecosystem. So we're going to turn off data sharing. That requires a lot of change in practices and behaviours beyond the technical architecture, but it won't work if the technical architecture doesn't actually allow data to flow to where it needs to do to answer the research questions that we want to be asking. So I think there is a shift over the next 3 years in terms of what we see in terms of system architecture. The policy will push people in one way in terms of requiring trusted research environments to be accredited, requiring them to be the default means by which NHS data is accessed. So we're pushing people, but I think we also need to optimize those. And again, it's sort of partly coming back to Ben around they need to be effective and actually deliver. Those need to be usable services that people can actually do the things they want to be doing with the data they want to access at the scale and speed and efficiency, which comes back to then IG, commercials, contractuals. Are we actually supporting data quality? Are we ensuring, in fact, that we don't create 7 to 10 TREs that don't link and talk to each other? So it can be great to switch off data sharing if we can move to a linked network of assets that will actually communicate and collaborate with each other. So there's a cultural piece, there's an operational piece, and then there's that policy piece that will help support us in pushing the landscape in the right direction. But I don't think it's an ecosystem-wide approach, and we'll need NHS England, UKRI, NIHR, and others all pulling in the same direction as we try and reshape what the landscape looks like over the next 3 to 5 years.
Yeah, getting the liners aligned to go across the Atlantic together is going to be quite an achievement, I guess, isn't it? Have you drawn from the genomics rollout as to the processes that will allow that to happen, to link people together?
So I think we're really absolutely trying to learn not only from genomics, from GMS and the regional genetics labs, but the LICAS programs from HGO UK hubs, from the Centres of Excellence, of which I ran one. There are a range of things that some things have worked well, some things have worked less well. There are pockets of excellence. And again, and I'll call out Open Safely, not to make Ben and Jess blush, that there are an awful lot of lessons we can learn from there, but it doesn't do everything for every use case. There's a bit of saying, how do you scale this up across the country, across the full richness of imaging, genomics, pathology, EHR, primary, secondary, and how do we do that alongside the emergence of ICSs and ICBs? And whilst people are going through EPR implementations, there's a lot of change we're asking of people all at the same time. And so there's a job on me and others inside NHS England centrally to align and coordinate that, to make it as clear that we're all headed stepwise in the same direction, and make sure that the investments therefore stack on top of each other so that data can flow for care planning, pop health and research in a much more joined up way. And again, that sort of comes back to Ben's point around we can't be having multiple collections of data that flow off into different silos that can't. We should collect once, curate once if as far as possible, and use it across those use cases. But that's really going to require a change in terms of local, regional and national practices in terms of data use.
You partially answered the next question I was coming on to, which was around what should be included in the upcoming publication of the target data architecture for health and social care. So you remove those barriers around data storage, curation and sharing. Are there any other things that need to happen to make sure that occurs? And I'll come to Breid if I may.
I think from what Ben and Claire have said, I think we've covered most things. I guess just picking up a couple of things in the chat would be about how we, in the publication, how we frame it for different audiences, because I think language matters. And I think really understanding who it is in the publication, who is it we're trying to impact, because data is a word that we're talking about, but actually for lots of people more meaningful is the word information. I think Suzanne popped in the chat. So really just thinking about the language we use to engage everybody. And I think that whole sharing point, and I think Claire just said, collect once, curate, but the fact that it's then available for multiple uses, that's the really key thing, because most people want to know that they can access it when they need it, whether that's for direct care, research or whatever. So for me, they're probably the most important things, but framing and the language is really important.
And just to follow that sort of trend in better data saved lives, we're talking about a much more trusted environment that patients can and citizens can trust. Do you think where we're going, and I'll go to you, Claire, if you don't mind, with these sort of policies at the moment, is going to get across to the public that their data safe?
So I don't think the policy alone can do that. I think, again, public confidence, as I call it, rather than necessarily public trust in how we're using data, how we're managing their data on behalf of them across the range of use cases, is an ongoing conversation that needs to be had as a regular drumbeat. And we've heard that from understanding patient data and others. I think we are looking at a real shift away from programmatic individual conversations around, I would like to use this kind of data for this kind of use case for this specific reason, and that we need to have a much more comprehensive overarching conversation at a national level, backed up locally and regionally, around how data is used across care planning, population health and research. What do people feel is okay or not? Why? At what level of the system? And therefore designing and co-creating and implementing those investments that reflects that, and recognising the way that a group in London may feel may not be the way that a group in Manchester or Truro will feel about data. And we have to consider and respect that in the way we're thinking about how we're collecting, storing and making data available. So there is a shift, and I think data to save lives, it puts trust and transparency at the start of that document for a very real reason, that it is the fundamental by which we need to progress everything. But that we need to do it, as I say, as an ongoing regular rhythm, and just we should be talking about this all the time across all of the use cases, and not assume that we have public confidence and then think we've done it and tick the box and we can move on.
Thanks. I think James will move on just for time constraints at the moment.
Yeah, no, thanks, Mike. And it's a really interesting conversation there. One of the things that I would pull out as an improvement, I think, from the interim to the final version of the Data Saves Lives was actually a much greater emphasis on this point about public engagement, and that being a responsibility on all data controllers, not just to do it once and assume that you've cracked it, but to be an ongoing relationship and discussion with the public about how their information is being used to improve their care, the care of their loved ones, etc. And we know that that, together with some of the more technical fixes on security, is a very compelling argument, but it has to be made. You can't just assume it. And I think that's the point that you're all making. Corinna, can I come to you for the last question on this topic?
Of course. Thank you, James. I think, you've made a really good point, Claire, about what we need is usable services with IG commercials, contractuals that work. But how do we make sure we're doing that not just across primary and secondary care, but also into ICSs and crucially into social care, particularly if we think that a huge number of care homes don't even have any kind of electronic system for managing their patients? How do we make sure this is truly universal and therefore can be used for the care planning and population research that you mentioned? So if I could come to Claire first, maybe.
Thanks, Corinna. So it's no small task. And I think, again, in the same way that there is digital maturity variability for healthcare records, the same holds true and is a step back in terms of a lot of the social care landscape. We know that there are a number of wider determinants of health that are critical beyond what the NHS directly holds. The Department of Health and Social Care is about social care, and we need to be, again, in the same way we're talking about learning lessons from the past from LICAs and HDI UK hubs, we need to do the same, leapfrogging social care data from some of the learnings from the NHS experiences as well. I think that there is a large weight on the shoulders of ICSs in terms of bringing together and coordinating a lot of that activity. But I think everybody's keen to see that as a success, and that everybody understands why we should do it. It's just allowing the time and space for that shift. Again, they're coming in now. We're sending out the guidance in the next few months. There's a huge variability in terms of the constituent parts of those ICSs and regions to work through. But that's why I think, again, it's back to incremental but impatient. We won't fix everything overnight. We need to be cognizant of all of this, not just social care, citizen-generated data. There are a range of other strands we will need to be pulling through over time. So it's a sense of what can we do quick wins, but what builds and continues to allow interoperability and standards that will allow other data sources to feed and flow. So I think two things that will help us are, one, embedding the research requirement into ICSs, so an explicit expectation of thinking through that as part of their model. Research often pushes the envelope in terms of some of the practices and expectations we put on our partners in the frontline and in the ICSs. And secondly, that we're actually, through Data for R&D, we're investing into the ICSs and regional investments for trusted research environments. So it's not a case of pulling everything nationally, it's a case of working with those regional environments to really allow them to pull the local richness that exists into regional data assets as well.
Thank you very much, Claire. Conscious of time, Ben or Breid, any final thoughts on this topic before we move on?
Just one small thought, if I may.
Go ahead.
The best way forward with these kind of complex technical challenges to work iteratively. Agile is a word that has become fashionable and therefore diluted in its meaning. But in the review, we suggest starting with maybe 3 ICSs where you over-resource them because you're doing discovery, you're generating templates that can generalize to other settings, where you get a small cadre of people who really understand how to work in a trusted research environment. You develop skills and capability around open methods. And open methods is not an abstract good in its own right. It's about having practical shared code and methods on things like data curation for others to use. And on social care data, it's more crucial than anywhere else. I have worked with small amounts of social care data locally. I've never been able to find anyone anywhere who has shared their code, their data discovery, data quality work, data curation work on, is this patient in a residential care home or not? Are they in a nursing home or not? What's the cost per day? What's happening to them? Where did they come from? Now, the only way to start building out in this space is to start doing the technical work and then doing it in the open so that others can learn from it. And I think the biggest disaster, and I think it has been a bit of a disaster with the digital innovation hubs and especially the Lycas, is that they have been so closed. They have been black box services where there is an external facing surface. There are some PowerPoint slides and perhaps some finished outputs, but there has been no culture or expectation of people sharing the technical work that they did under the bonnet to produce a shared data set, a shared technical environment, and so on. Now, that's not necessarily a criticism of the individuals involved. It hasn't been an expectation of the system, but I think we need to wake up and start recognizing that data curation and secure analytics and running platforms for other people, that's the hardest bit of the job. That's the bit that's interesting and new and difficult. That's the bit that's holding back everybody else. And that's the bit that has suffered for lack of an open commons of knowledge and a competitive and collaborative ecosystem. It's been black boxes where nobody can see what's under the bonnet, but the stuff under the bonnet is the most important part of that work.
Thank you.
Very good. Well, that's a brilliant note to end on. And I think in terms of a sort of call to arms about a culture change actually within the NHS, which I think can sometimes be a closed and inward looking system, and that idea of being much more open and runs through everything that you have done, Ben, and indeed that we've talked about this morning. So I want to say a huge thanks to our 3 speakers, to Ben, to Breid and to Claire. Ben, I believe you're able to stay with us for the second hour, but we'll say goodbye and thank you to Breid and Claire. Thank you so much. Really appreciate your time. You've been brilliant. And I am shortly going to hand over to Mike for the second half. Before I do, I just want to pick up one thing that was in the chat, topic close to my heart, which is around opt-outs. What's the best way to present them? What's the best way to simplify them? It's an interesting. So when I was in the department, we introduced the single national opt-out in May 2018, and one of the things that struck me after we'd done it was that it was the sort of bare minimum that we could possibly aspire to, was to get people not to opt out. And if you think about it, and of course you need a legal opt-out, but sort of it's completely the wrong premise to start from, because the right premise should be you want to opt in, or you don't need to opt in, but you want to opt in because sharing your data in the ways that we have described with a skilled up workforce with technically secure environments is going to be a good thing. And that, as we said, is a message that does resonate. And we don't actually have many mechanisms for giving people the chance to express their desire to opt in and be part of something. And personal opinion, I think this is potentially one of the opportunities that the app, the NHS app, has to have that conversation, ongoing conversation with people about that. Now it's on 27 million phones, and that could be a platform for having a properly engaged ongoing engaged conversation with the public about the benefits of their data being used for a multitude of purposes. So anyway, personal hobby horse, but it was there in the chat, so I wanted to pick it up. So Mike, I'm going to hand over to you now to introduce the second topic and the second set of speakers.
Thank you very much, James. And it's always good to get your hobby horse out of the way before you leave as chair, I think, isn't it? Thanks for doing that. I was picking up one of the other comments in here about, and we're talking about language and getting patients more involved and engaged in this, and citizens getting engaged in it. And I think I'm just going back to the Suzanne, is it, who posted that we shouldn't be talking about data. It's health information, and people are closer to that rather than just sort of anomalous sort of terms such as data for them might not be as meaningful. So I guess we've got quite a bit to go in explaining to the public about what we're doing and why we're doing it and why it's in their interest to do it. I'm delighted now to go to the second half of this first commission, and we'll move on to the sort of life sciences vision. But I'd like to introduce the panel that we have. Ben, I'm not going to ask you to introduce yourself again, if that's okay. But Cathie Sudlow is here from the Director of BHF Data Science Centre. We have my former colleague, Maureen Baker, who's the chair of the Professional Record Standard body now. Shane Tickell, who I've worked with before in terms of digital health, and pleased to see him on the call, and Tim Sheppard, who have also worked at IQVIA. And so I'm going to ask them to introduce themselves if I could. So Cathie, would you mind introducing yourself first?
Yes, thank you very much. Cathie Sudlow, like Ben and many others here, I'm a clinician by background with training in epidemiology and health data science and expertise in linked healthcare data across the UK. I worked for some 8 years as the chief scientist for UK Biobank, which is a research resource many of you will have come across. And in the last couple of years, I've been director of the British Heart Foundation funded Data Science Centre, which is embedded in Health Data Research UK. Am I supposed to do this kind of 2-minute thing?
I apologise. Your chair should have said you've got around about 2 minutes. Carry on, thanks.
So one thing I thought it might be useful to do, and if you'll indulge me, I'll share my screen. Oh, I'm disabled. Am I allowed to share a single slide just to show for people who may not have come across the concept of a trusted research environment, a picture? Don't have to, but...
I don't think we're going to be able to do that, Cathie.
Okay, never mind. So one of the things I've had the pleasure of doing in the last couple of years is working very closely in partnership with NHS Digital and other colleagues across the UK with major national data custodians, and in particular NHS Digital. So at the start of the pandemic, there was no trusted research environment to hold the entire population's worth of linked healthcare records, many of which existed, but which had not been brought together in the safe and secure way that we've heard Ben and others describe. And so that trusted research environment for England, hosted by NHS Digital, now exists and is populated with a large number of different data assets, each of which individually is powerful for deriving health intelligence for planning and research. But when they're all linked together, the power massively magnifies. It's possible to fill gaps. It's possible to surface where there's a duplication of effort. It's possible to resolve errors. And then the second thing that I've had the pleasure of being involved in is starting to pull together a health data science team based within Health Data Research UK, but working in close partnership with a new and building data wrangler team within NHS Digital to start to work along those curation and data management pathways, producing reproducible analytic pipelines, very much following the principles that Ben and others have laid out for many of us to follow. And so I'm a great proponent of close partnerships between academia and the NHS, and increasingly industry as well, and creating posts and roles that can navigate their way across those different entities to add value for the whole research community.
Thank you very much, Cathie. And that was a very succinct and informative introduction for us. Maureen, it'd be lovely to hear from you next.
Hi, Mike, and hi, everyone. Good morning. So my name's Maureen Baker, and I'm chair of the Professional Record Standards Body. And I'm also Chief Medical Officer for Healthily, which is a self-care web platform and app. PRSB is a not-for-profit community interest company, and we develop information standards to define and structure information in electronic health and care records. We're a member organisation. We have 77 members now, and they consist of all the medical royal colleges, most of the important professional member organisations across the UK. We also have regulators, we have NICE, and very importantly, we've got good social care connections, such as the National Care Forum, and we also work with people who use our services through our patient representative members and our people network. Also, very importantly, we work with system suppliers through our standards partnership scheme. Now, I've got, as you probably know, Mike, I've got a lifelong passion for patient safety, which is why I got into this gig in the first place. And it seems to me that, well, it's clear that data quality is a patient safety issue. You can't ensure patient safety without understanding what the data is telling you, and you can't understand and interpret data, health information, if it's of poor quality. To provide safe care, we also need to know what's important to people and what they want from their care. And this data must be readable and shareable. If you can't understand the data, how can we use it in the way that we want to for data analytics, research and life sciences? So that's really the main message I want to get over today, that we need to be able to collect, extract data that is consistent, that means the same across different settings, that can be shared, and that we can do this in partnership with the public, with the professions, and with system suppliers.
Indeed, data does save lives, Maureen. You're absolutely correct on that.
It
does. Shane, I'm going to move on to you now. Thank you for joining us.
Thank you for the invitation. I'm Shane Tickell. I'm CEO of two companies, Temple Black Quantum Health Technologies and another one called Varroa Health Technologies. And we're in the business of data today. I've spent 25 years in electronic patient record companies, but the last 2 years have been primarily around data. And I'd like to give you some evidence today of where data is being captured real time for use for direct care, immediately used for population health, and immediately used for research at scale. I also have another couple of roles, and one is I'm Vice Chair of the Tech UK Health and Social Care Council. And as part of that this year, I'm also chairing the Frontline Digitisation Forum between the NHS and the excuse me, EPR suppliers. What I wanted to mention today, and I'm a great fan of not only the Goldacre review, but also some of the things that have already been said this morning about capturing that data and cleansing it. So I'm going to put a link in to a wiki page shortly about the Discovery Data Service, which is in use in London. And it's currently supporting 3 ICSs, North East London, North West London and South East London. And primarily it has captures live data from about 890 GP practices, but also live data from places like Barts, from Imperial College, also from mental health, community, and about another 120 other services. And that data, once it's been connected, is actually coming in live. And what we've done, and what I would point out, and what I would hope to maybe address one of Ben's last comments about things being done under the hood, this is all being done in open source fashion, and it's being done and shared because we want other people to use it, not just throughout the NHS, but actually throughout the world, that it can be done. And I'd also draw on another couple of things. Most of the people that are in my team have got over 20 years of experience. Not all of them have long CVs of qualification, but they do have really hard years of graft where they have built things like, the EMIS cloud. So we have about 14 or 15 people running and managing this data in a live real-time fashion. And just to give you some idea of size, it's supporting over 7 million people in London today. We've collated over 33.5 million records. Those records are increasing at about 2% per month, so it should grow by over 20% this year alone. And what we do with that data is we use our hard skills and experience and knowledge to normalize the data. So one of our frustrations was simply that I've spent 20 years trying to get people to work on standards. We've set up organizations, we've done all sorts of things. And though we are great fans of the PRSB and Interopen and others, it is still taking too long. So we take the data where we can, we normalize it to a SNOMED code. Where we can't, we would apply for a SNOMED code. And when we can't do that, we have created this open source library called Information Modeler, which today has over 3 million terms of reference in it. And just to put into some kind of scale, that data is being used live, for example, for frailty flagging, whether it's NHS 111 or whether it's London Ambulances calling on that. We're getting about 340,000 calls a month, and it's growing by 10%. That data is being used by Queen Mary's and was formerly used by, up until recently, by Oxford University's Nuffield Primary Care Department for analysis on people who've had vaccinations and heart issues. And it's being used for population health, all from the same data sources. And what we're looking to do is get more data in, cleanse it more, and share it more. So that's going to be the basis of the sort of things I'd be offering to talk about today. And hopefully that will address some of the questions that you've got, Mike.
Thanks very much. And it's great to hear successful examples. And one of the aims of this commission is to actually look at case studies where you have been able to do things at a reasonable scale, be able to then use that for adoption nationally. So thank you for that. And finally, Tim, are you able to join us now?
Yeah, hi, Mike, and thanks very much for that. And thank you for inviting me to join. It's great to see so many colleagues from the last 15 years of my career, I think, across, maybe even longer, but we won't go there. I lead the IQVIA business in North Europe. IQVIA is a global clinical research company. So I guess when we come to this discussion, I'd like to bring the perspective of global researchers. As you can tell, I'm British, and I'm keen that as much research comes to the UK as possible. We use health information for clinical research, often using data sets from the UK. We also use that information to improve the delivery of clinical trials. But we also work with health systems around the world, including the NHS, to use their information to improve data and insights and outcomes for patients. I think there are two key points I want to make today around this debate. And one is that for global clinical researchers, whether they are working in large pharmaceutical companies or very small pharmaceutical companies, or indeed in academia, are often searching for the best place to most efficiently and most effectively run their research. And it is a sort of global competition. As I said, I have responsibility across many countries in Europe for our business. And I see what colleagues are doing in Netherlands and the Nordic countries particularly. And so the UK is not the only country that is on this path of preparing its data for use by global researchers. And we need to be conscious of that, and we need to be ensuring that, you know, the fantastic data assets that the National Health Service has, the contribution of the patients to that, the willingness of patients to take part in research is part of that. And we're seen in the context in that global context. And we want to attract researchers to our country to conduct their research here, which ultimately and significantly benefits UK patients. The second point I'd like to make, and I really loved the first hour, and I can't possibly attempt to comment on some of the complexities of setting up TREs and how that will work. And we welcome at IQVIA, we welcome the Data Saves Lives policy document was published last week. We think that's fantastic, and we can barely find anything in it to disagree with, which is unusual for us. But the thing that strikes me when I work around the NHS is the most inspiring stories are often very local or regional. And I think we need to set the regions and the local organizations free in this endeavor to drive innovation. I'm struck, and I don't want to trivialize the importance of healthcare data, but I'm struck by the example of Transport for London, who've made their data as accessible as possible. I've driven a huge amount of innovation off the back of that data in terms of apps and tools that can be used to help people traveling around London. And I somehow see if healthcare data could be used in the same way and make sure that the access is free enough that local innovation can flourish. So, thanks.
Thanks again, Tim. I think you bringing the international comparisons is very interesting, and obviously the pace of change in different countries we could learn from as well in this. Anyway, I'm going to move over to the third topic on the agenda for today, which are the life sciences vision, which highlights the benefits to patients. And James, I think you wanted to ask the first question in this section.
Yeah, thanks, Mike. We've talked a lot about the multiple uses of data to inform better care, better planning, and research, and we sort of focused a lot on more academic research than perhaps commercial research. So I wanted to move into quite a sort of thorny topic, really, which is to ask, how should the commercialization of data be carried out or controlled in a way that generates value for the NHS as well as for UK PLC in the way that Tim's just described, but also making sure that's done in a fair and appropriate way, such that the benefits accrue to those people whose data is being used to generate value. There has been a promise of a value sharing framework from the NHSX, as was not yet published. So this still feels like an area, a bit of a lacuna in the policy framework. So I'm really interested to get perspectives on it. I think, Mike, because there's so many speakers, we probably can't ask everybody that question, but I wonder if I might ask Shane that question first and then Ben.
Thanks, James. So I think value to me comes down to pence per citizen per annum. And I think if we are providing back value to the people who are collecting and using and sharing that data, and if I can, I'll elaborate shortly on that. But I'm not sure if your question is actually aimed at the public and themselves, because my view as a citizen is that data doesn't really cost me anything. And I'd say 99% of the people I talk to anecdotally don't want some kind of direct return on that data. What they do want is to see it used of high value. And I'm a fabulous fan of the imperial studies that have shown that the vast majority of people in the street want to see the NHS benefit from that. So I think there's an argument that says there's nothing that needs to go back to the citizen. What I would argue is some of the funds, and the funds that I've involved in the £2 billion frontline digitisation fund, and we've got the £360 million fund for the federated data platform, and then we've got this fund for the TREs. And actually, I think if we were able to, as industry, I've worked on pence per citizen per annum kind of costs. I can work on that really easily. And if I think to the GP who's providing the frontline care, I know they know how much they're getting paid. And so for me, a fairer system would perhaps be based on some kind of recognition of that data and an encouragement for the ICSs to start gathering that data and providing it, perhaps in the next 1 to 2 years. Because I feel at the moment that the ICS are in very different places of how they're going to gather that data. So for me, a commercialization model would look at a population, and perhaps where we have rural populations. I'm from Cumbria originally, but I live in London now. But we know the least densely populated area, but with some of the highest needs. So there needs to be a little bit of leveling up, but pence per citizen per annum is a really good model, both directions.
Thank you. Ben, and then maybe Cathie as well.
I'm not quite clear if we're talking about commercialization in the sense of how do we incentivize folk like Shane to do good work on the data, or if we're thinking about some external party coming in and working with NHS data to then produce a new product. I mean, I'm happy to. Okay, fine.
Or either, yeah.
On life sciences innovation, people coming in to work with NHS data and then developing a great new product or algorithm or tool or insight. I think historically there's been a lot of anxiety, in particular because our model of accessing data, disseminating it out to hundreds of different locations, has folded together two different unrelated issues. One is protecting patient privacy, and the other is the more deeper sort of moral and political and cultural question: how do you feel about commercial entities profiting from accessing NHS data? I think the most important thing as a first step is that by building TREs, we can disaggregate those two questions, and we can then say very purely, this commercial company wants to come in and work with your data, your privacy is protected. So now, standalone question, what do you think about this? My personal view is I'm pretty relaxed about that, as long as the NHS takes some kind of cut of it, of the profits. but it shouldn't be down to me. I think the right way forwards here is to do robust, standalone, in particular, deep dives from things like citizens' juries.
Yeah.
And I thought what you said earlier about PPIE was actually really powerful, because PPIE is an area where we've seen hundreds of duplicative and often quite small projects on PPIE, which has not been very helpful. I think much better is to have some really, really robust, solid deep dives on these single standalone enduring topics. And I think that's how we'll get more forward plot movement, because we need to recognize who has injected the most value into the service, into the innovation pipeline. If you pick up an open source random forest AI software library and throw it on top of tens of millions of patients worth of GP data, then you will instantly start generating quite interesting findings, having not done very much work yourself at all. I don't think it's appropriate for the person who does that to capture all of the value of that work, because the time and investment of the NHS collecting 58 million patients' full longitudinal health records back to 1946 in England alone, that was a huge investment, and we should be expecting to get something back on them.
Yeah. Thank you. I just put a link, or tried to put a link, I'm not sure if I was successful, to the Imperial College 1 London citizen jury process, which I think you mentioned, Shane, and which I always have in mind, having sort of sat through them, being part of it, is just a very, very good example of well-structured citizen engagement at scale around this topic that produces really interesting results. So people might be interested in that. Cathie?
Yes, I don't have much to add. I think Shane and Ben have both made fantastic points. The only thing I would add is that there are large consented research studies which serve as good models for how to attract really great inward industry investment that benefits everybody. I mean, not just in the UK, but actually globally. And UK Biobank is a really good example of that, where building a fantastic resource has then attracted fantastic inward industry investment to genotype, sequence the whole cohort, add all sorts of other value, imaging, sample assays, et cetera, that have been for broader benefit. So actually thinking of the NHS and its health data assets in a similar way. So, you know, through the building and sharing infrastructures such as trusted research environments, being able to attract considerable inward industry investment to improve and enhance those assets for mutual benefit. So not just about the use of the data and the profit share, but actually the improvement that can come from inward investment.
Yeah. James, if I may, I wonder if Tim has any comments on this about international comparisons.
Indeed, yeah.
Yeah, I mean, I think it's important to make the barriers to entry as low as possible, and all research should be appropriate. And but I do think, you know, that there needs to be a significant test on use of the data, that the researcher can demonstrate what the benefit is back to the NHS. And I think if every researcher is asked that question and has to articulate it, you know, I think that's probably enough in checking that the NHS patient is going to get benefit from what their data is being used for. You know, we in Rotterdam this week was a very large symposium on healthcare data, and I was really surprised at how many organizations there are across Europe talking about the great data assets they have. It's certainly a kind of flourishing environment where many countries and regions are trying to attract researchers to come to their country or region to conduct their studies. So I do think we need to be conscious of not raising barriers.
James, have you any final comments before we move on to the next?
That's great. Unless Maureen wants to make a comment, I'm very happy to move on. Thank you.
Well, I was just going to refer to the topic that's coming up, but we haven't mentioned here the views of professionals. Now, clearly, with patient data and their views about what happens to their data are paramount, but we have experience, in fact, we've got lots of experience in the past where professional communities have been very suspicious and very vocal about the use of patient data, particularly for commercial reasons. So it seems to me that it's actually also really important to get professional communities on board. One way of doing that, I think, is to be able to clearly demonstrate the views of the public through mechanisms that we've already discussed.
Thanks, Maureen, and I'm sure we'll come back to some of the professional issues in a few moments. Keith, are you going to continue the questioning now?
Yeah, thanks, Mike. And in many ways, building on what Maureen's just said, as an example, I spoke recently at an integrative medicine conference in the context of my overprescribing review, which some people might be familiar with. And I think it's fair to say there was a lot of suspicion in terms of data use and so forth. So, and that audience was mainly professional, mainly GPs. So in that, maybe I'll ask Maureen first of all then, and then perhaps come to Tim and others who want to comment on this. But so what actions, what other actions could be taken to ensure data can be used in a way that is supported by patients and attractive to life science investors, so that innovations are widely accessible to the NHS? So perhaps, Maureen, do you want to continue?
Thanks, Keith. I should maybe have said at the outset that my background is as a GP, and I'm a former chair of the RCGP, and it's like a perennial issue. It's over the last 20, 30 years, as you well know. Building on what I was saying before, I think professionals are sceptical because they've got reason to be sceptical. They've seen schemes before that weren't properly thought out, that didn't properly attempt to capture views of citizens and patients. And they're also very well aware of the power of personal data and in their own hands, as it were, and what that can mean for people. There are also issues that haven't been raised so far. So GP records, for instance, the issue of third-party data. So making an observation in one person's record about someone else. Now, the classic case is domestic abuse, for instance, or child safeguarding or elder safeguarding. These are issues that the professions as yet don't really see clear, coherent ways out of. So it seems to me that learning from the past, it's actually really, but not just to say, here's a group of professionals and they're blockers, I'm going to do it anyway, which, frankly, has been tried before. But here's a group of professionals and they've got some really cogent arguments. In order to do this properly, we've got to be able to answer those arguments and therefore explain to the professionals and indeed citizens and patients that this can be done with good governance, with ethics, with equity, and try to take those concerns on board, properly work through them, and be able to deal with them in that way.
And just one further before I come to Tim, then do you think the sort of shared decision-making process, personalised care, all of that, well, it's more than movement now, isn't it? Because its time has certainly come, it seems to me. Could this be built into that? Do you think, Maureen?
Oh, sorry, I thought it was you raising the question to Tim. I definitely think so, absolutely. And I agree with you that the time has definitely come. In fact, PRSB has recently published its shared decision-making standard, a good opportunity to raise that. But yes, the concept that people who are properly informed, who understand their options, and can consider those hopefully in partnership with a trusted professional, and then clearly can decide about the use of their data, or their views on the use of the data, that's all part of this wider conversation, I think.
Thanks, Maureen. Tim, comments?
Yeah, I think one thing that's hindered the country in terms of attracting global researchers in the recent past is that it's never been very clear in how the data is to be accessed and what the rules are around it. And no matter what those rules are, I think if they're, following the discussion we had in the first hour about TREs, as long as it's very clear to everybody exactly what the rules are around accessing the data, what the requirements are, I think that really needs to be laid out for global researchers, whether they're commercial researchers or academic researchers. I think those rules of access need to be clear and they need to be consistent. I think we have in the UK at the moment a plethora of very interesting data sets, but with different access requirements. So I think we need to try and provide some consistency there. And I think that will also support reassuring patients that their data is being used in a consistent and fair way and in an appropriate way. I think of some of the use cases we have for data in the UK: drug discovery, improving care pathways, allowing pharmaceutical companies to demonstrate the efficacy or not of their medicine, finding patients for clinical trials. All of these things are hugely beneficial activities, but unfortunately, to Maureen's point, some other use cases have not been quite so worthy, let's say. And I think we need to make sure that we guard against those. And then finally, to one of the points in the chat, I think the technology exists now to make it clear to a patient what their data is being used for, and to give them the opportunity to opt in, opt out, opt back in again, opt in for certain things and not for other things. And I think whilst we all hope that 99% of patients allow their data to be used for lots of different purposes, I think by giving them the option, it builds trust.
Conscious of time, Mike, and I think we're going to build on this sort of subject in the next section, but up to you, we can carry on.
Okay, thanks. Ben, have you any comments on this particular area?
Well, just one on coordinated decision-making, and appreciating that a lot of people in the public are happy with their data to be used in general, or not, in broad brush terms, but probably don't want to be pestered about each individual choice. And I think one of the most problematic things that we identified during the review was that 6,000 GP practices are invited to make decisions separately about data access for things like UK Biobank, but also for the large GP data aggregation projects, some of which are actually quite concerning in terms of privacy engineering and access. And what you see there is the problems caused by inviting 6,000 practices separately to decide, on the one hand, whether to share patients' data at their request with their consent to the UK Biobank, also asking 6,000 practices separately to make a decision about whether to give their entire patient record archive to a wide variety of different aggregators of data for subsequent on-selling, for subsequent downloading. And that really makes very little sense. So I think we need to be very cautious about creating governance frameworks which, by pursuing the goal of individual choice, end up creating a needless, overwhelming volume of confusing decisions for people who may not particularly want them. In the review, we recommend, in particular, consideration of whether there should be a voluntary trust that practices and trusts could sign up to and say, look, we trust this organization to make sensible choices about access to our data, just to try and duplicate some of the decision-making around that. And I think it's the same for patients, because otherwise we'll very rapidly get into a situation where everything is bogged down in those kinds of micro choices.
I totally agree with you. And at some point, we have to have a process that's trusted and effective and efficiently uses that data so that we're getting good decisions from it without having to revisit it every 10 minutes for a second topic or so. We've delved in and moved on to seamlessly the final topic, for the fourth topic today, which is about protecting patient privacy and incorporating patient preferences. So we've touched on that. And I'm just going to ask the initial question, which is around how can that privacy and security of patient data be ensured so that programs such as the TREs can be adopted at scale. And perhaps, Cathie, you'd like to take that one first, as it's an area of interest and expertise of yours.
Yeah, I mean, there are sort of technical issues here, and we don't want to get too bogged down in the technical, but I think there are a range of different solutions for different use cases. So, some types of data use require aggregated data only. There's no need for any person to be identified or at risk of being identified. That's fairly straightforward. There are use cases where a data set can be completely and irreversibly de-identified. So it's really important to identify what those are and make sure that that's the route that's used where appropriate. And then there are those use cases where you need to be able to re-identify individuals because perhaps your inquiry is going to alert you to some kind of safety issue where, so you want to conduct the inquiry perhaps with de-identified data or data where you can't identify individuals, but you need the link to be able to be made so that those individuals or their clinicians can be alerted to a particular issue or whatever. And there are different approaches to that. And I think it's just really important to think through what sort of structures are required within trusted research environments to enable these various different types of technical solution. And in my view, we don't yet know which solutions are most appropriate for all of those different instances. And it's important to have a smorgasbord or at least a range of different solutions being tested out in safe ways so that we have the best solutions for the best purposes.
Thanks. And Shane, you must have to look at this from a slightly different point of view, using it commercially. I just wondered how you approach this.
So we have actually it's a prototype, but on the data that I've talked about, we had something that sits on the top, and we actually, we built this for demonstration purposes, whereby we could look at, say, a street, and we were looking at the time, the spread of infections of COVID. We could drill down into the individuals where they were mapped on the street. We could look at populations, and there we could actually drill into, if you had the appropriate access, the individual citizen's record. And this could be for many purposes, not just their clinical care. There were safety issues. There were all kinds of reasons that we can do that. So I would argue that we have not just a duty, but we have a technological ability today to provide security on patients' information that is way and above anything over that we had with paper. And I have some horrible examples of paper records being seen, left and shared without denigrating the importance of protecting everyone's data. And Maureen gave a classic example of somebody's immediate and real-time security. I think we've got the imbalance very wrong at the moment. And I say this from 25 years of running sexual health systems that used to send text to phone saying, yes, you are positive, to dosing on anticoagulation therapies via voicemails. In them days, we had tape recorders. But today we have examples where we've got over 500,000 potential diabetic people in Northwest London, where because we've got 6,000 of those records have 3 email addresses and 2 phone numbers, and we're not sure which one to use, 98% of those people are not being communicated with. So, and internally, I think it's the professionals who are really insecure about opening up that data. And technologically, the example I've given you as a prototype is very, very real today. We can anonymize, pseudonymize the information and come back to that real information for the people who have got the right reason to access that at the time. And my final point actually on all of this is, as professionals, whether you are a healthcare professional or you're an informatics professional, I think it's right to say you should be trusted and you should be held to account if you break that trust. And I think this is about explaining this to the public. Thank you.
I suppose that comes back to some of Ben's first points on the training and always the stature of the information analyst, the information person within our system at the moment. I'm going to move on to the next question now, and Richard Stubbs, thanks for helping.
Thank you, Mike. And I think in the interest of time, Karina and I were just talking about putting our next 2 questions together, and I've drawn the short straw to try and do that.
Well done, Richard.
I didn't move fast enough. So as Mike, you said before on the previous question, some of this has been touched upon already, but we have had some really interesting comments in the chat. So I suppose part A of the question is really just think about what are the factors that have to be considered in order to enable patients to have more agency and control of their own data. So we've just been talking about security and trust, but just a few comments on the panel on agency and control. And just to move from that to think about, do we go on to then develop a public data pact, which ensures transparency around the use of health and care data? So question really about patient agency, patient control, and moving towards a public pact. Ben, could I come to you first, please?
Look, to me, the single most important starting point is that we stop sending copies of millions, tens of millions of patients' data to hundreds of different unknown and uncounted destinations in a chaotic and outdated fashion. That has to be the starting point. And a failure to recognize the challenges of that has had such huge consequences. It's resulted in 1.5 million people opting out of their data being used with care.data. And then again, another 1.5 million people opting out when we tried to do it last year. The thing that has brought me the most, the thing that's really pleased me has been over the past year, watching across the system a growing recognition that removing names and addresses and sending data out is not an acceptable way to go about making data accessible. And I think hopefully we'll never go back to thinking that that's normal. However, the place where I worry that lessons have not been learned is when people talk about these data aggregation projects in terms of the need for better public engagement, for us to tell people that what we're doing with their data is brilliant, that it will improve patient care, that it will drive innovation. I think for the most part, where people think about it at all, they recognize that value. But the problem has been that they have also recognized that historic approaches to how we manage their privacy have not really been fit for purpose. And I think if we want to get public trust, it's important to do engagement. It's important to tell people that what you're doing is fantastic. But the foundation, the starting point has to be that you earn that trust by taking provable, transparent and credible steps to protect patient privacy and being transparent about everything that you do with their data. And I think nothing else matters as much as that. Nothing at all. And so that has to be the focus of our work. And that needs to be the focus of our work in delivering TREs, but also in making sure that we don't build what have recently started to become known as TRENOs, TRE in name only. A TRE needs to be a shared environment, because as soon as a TRE is for one internal group, it rots and just becomes like a shared drive. It needs to have privacy preserving tools in it, and it needs to have absolute transparency about every action that's performed on the underlying data. And if we do that, then we'll get public trust. Open Safely is the TRE that my group has built, and it has active, positive support from the professional groups and from the campaigners like Med Confidential, who have built their lives out of trying to block similar scale data sharing projects in the past. And what that shows me is that where you listen to people's actually sometimes, well, often quite reasonable concerns about privacy, and then develop new methods and tools to work around those and to mitigate those risks, and you explain how you've mitigated those risks, then you get public trust. I think endlessly asserting that what we do is good will get us nowhere at all.
Thanks, Ben. Brilliant. And because this is the final two questions, actually, I am going to come to each panelist in turn just to give their 2 minutes on the question before handing over to James to conclude. So, Cathie, to you, the same question. You know, what are the factors that we need to consider to give patients more control of data, and how do we move towards a public data pact to ensure transparency?
So I think it is exactly that. It's being entirely transparent about what data are being used for. But I think it's also about making sure that this is done in a language that is accessible, that everybody can engage with, and that everybody can understand. And I'm noticing in the chat there's some really good comments coming in from some people who I know sit on public and patient panels, so Susanna Power, for example, calling for the need to put health data sharing in a context that all patients understand. So I think we just really have to keep working at this language, and we need to make sure that we're providing information in formats, a range of different formats for a range of different people. Many of the people who are engaging in the public patient debates and panels at the moment are articulate and highly educated, come from relatively privileged backgrounds, and we need to make sure that we're doing this in a way that's far more inclusive than I think we do currently.
Yeah, thank you, Cathie. Completely agree with that. Maureen?
Yes, thank you. Everything Ben said, and then completely agree with Cathie in terms of the inclusiveness and the language that's used. So for me, that we tend to make assumptions. You know, an assumption being that people know what data is, for instance, that people know about, you know, how sharing and, you know, the way it's captured and the way it's recorded and coded, maybe a whole bunch of stuff we can make assumptions about. But I really think we need to be able to tell a story, which is sort of, you know, this is what we intend to do in clear language. This is how we intend to do it. These are the things that it could be used for, and this is the benefit that could be got. These are the risks. These are the dangers. This is what we're trying to do to guard against danger, and so really be able to give a narrative in, you know, easily understandable language with minimum use of assumptions, minimum, if any, use of jargon, and you know, and mean it. You know, mean what's said. I do think, as well as the Cathie talked about the inclusivity in terms of the whole design as well as governance. You know, we need to bring this sort of inclusive view in right from the start, I think, insofar as that's possible, and not just wait till everything's done and then be able to tell the story.
Maureen. Shane, your final thoughts on that question?
Thank you. Certainly, I agree with everything that's been said. I think there's a lot that Jess has pointed out in the Goldacre review. I think you start with a premise that we assume that people would want to give access to our data. The Data Pact, I agree with in principle. I think it's an awful name. I think it should be a data promise, and it should be a data commitment by the country to look after people's data. And in my own EPR businesses, we made a point of making sure our security was the same as whether it was defense information. If you give that kind of reassurance to people, you're going to treat it with such respect and care, then that might start to alleviate some of the issues. But I think really importantly, and I've said earlier that in the chat, people's ability to opt out and back in at different times in their lives. Opting in and out isn't spoken about. And I know, speaking to people who've been really reluctant to allow any form of data, once they have a family member that is, you know, either diagnosed or they find out there's a genetic problem in the family, then their need and call on that data just changes. So I think there's not much more I can add to what's already been said, other than that ongoing transparency. And frankly, every time I log onto my iPad and use Google, I have to press accept. And I am giving access to all kinds of data. And I know that's quite private data, but for my healthcare, coupled with the benefits of what we're going to use that for, then, you know, personally, I think we can appeal to the vast majority. It comes back to that word trust. And I think we should offer to update them periodically, whether it's annually or every now and again, what we're doing with their data, what outcomes and what benefits. Thank you.
Yeah, thank you, Shane. And the last word on this topic to Tim, please.
Well, thanks, Richard. Coming last has a disbenefit in that everybody has pretty much covered it. And I absolutely agree with everything said. Language, telling a story. And I love Shane's idea about calling it a promise, because it's a two-way arrangement, isn't it, as well? So I do think we need the use cases of data are are going to change over time. So whatever the promise is with patients who give their data, you know, it needs to be robust enough to stand up to the changes of technology and the changes of use cases that come up. But I thought that was a great idea from Shane. Thanks.
Thank you.
Thanks, Tim. Thanks, panel. Mike, back to you.
Thank you very much, all. I'll just wind up now. First, just to thank our speakers in this section, and also the commissioners who've worked hard behind the scenes here to try and get the questions, we hope, as pertinent as possible to the environment we're working in at the moment. We've been very privileged to have Ben Goldacre on the call today. I think we've now brought to life the Goldacre report, in my view, as to what it really means and how it can be used. And I guess, Tim, you were trying to sum up at the end there the sort of points that have been made in the last section, which is really around that sort of focused use of data. It has to be open and shared. And I like the Trino bit, name only. I'm sure there's lots of parts of medicine where we've dedicated ourselves to doing things well and actually just kept it quite insular. And I think also, Maureen, you've highlighted the fact that you have to win over the professions in this as well. We have a long history of not trusting change when it comes to accessing data in the system. But this is the time when data, I think, comes of age. And if we like, it's coming to help patients and to help the system cope with enormous problems, and also with the great revolution in biotechnologies that we're seeing. And so the vision for the life sciences ties into this very, very well. James, I'm just going to ask you if you want any final comments before we close the meeting.
Yeah, Mike, thank you. Well, obviously to reiterate my thanks to our fantastic panel, not just in the second session, who you've just thanked, but also to Ben, to Breid, and to Cathie in the first session. There's some sort of really important issues, I think, which we've raised and which I will take away, and some sort of memorable phrases around demonstrable security, demonstrable benefit to patients, deep and ongoing and meaningful engagement with citizens, the genuine sharing of value across all parties who are engaged in data usage, having a skilled and trusted and professional workforce across health and care and elsewhere. Obviously, trying to use best-in-class technological solutions where we can, and making sure in making the argument for wider data usage, of course, in a secure, trusted way, that there are health and wealth benefits to this, and these are compelling stories that we need to tell, and to which we know from experience the public are receptive to. If has been commented on, they are treated with respect, and their attitudes and thoughts and concerns in this area are actually dealt with in a sort of humble and productive way, rather than just assuming that it can be overridden. So yeah, a huge thanks to everybody. We've also had an incredibly lively chat, and thank you to everybody for participating in that. What we would say, and I'd reiterate something I said at the beginning, is come out that we want stories, we want use cases, that we want case studies. That's kind of how we want our work to be slightly different from what sometimes comes. So if there are things that you want to send us, if there are comments that, case studies you want to send us, there are comments you want to make on what you've heard, or indeed the format, and indeed, ultimately, we're after practical suggestions of what can change. If you think there's things that haven't been mentioned that you want to feature in the report, please send them through to us, and we'll endeavour to include them. But just finish off by saying thank you to all the commissioners, thank you to Ben, Harry, and others for their work behind the scenes, and a huge thank you to the panel and to the audience today. It's been a fascinating and, I hope, useful session to everybody, and look forward to continuing the conversation with you all.